Hi, everybody. Woohoo! It's our April session. It's almost May. That's crazy to anybody else. Yay! We have Palliative Care with us here today. Everybody's kind of like shifted to this side. So super excited to have Darcy and Rocco here. But first, as we always do, and everybody has a mouthful of hopefully really good food, we're going to do our introductions. So whatever you'd like to share, your name, what brings you out today, what your condition is, or if you're just here to hang out or heard that we have food, whatever the case may be. And then we'll go through that. Jamie's going to do a breathing exercise for us today to just get us grounded and ready for the good info that we're going to get today. So yeah, today should be amazing. So I'll start with the introductions. I'm Jessica Jones. I'm the patient facilitator for Better Breathers Club. Work closely with Jamie, Amanda, the rest of the staff, to make sure that the content we're getting every month is really good and juicy for everybody. I am a severe asthmatic, graduated from home rehab. I think it's almost like, oh, we could have a graduation anniversary party. I think it's been almost exactly 2 years since I graduated from pulmonary rehab. The things that we learned here, the things that we continue to learn in Better Breathers Club is just so good for us to keep living our lives as best as possible. Anyway, that's me. I always start with you. So I'll like to start with you today.
I'm Jeanette. I'm a lung cancer survivor. I have pulmonary hypertension. I came here today to play the harmonica group, which we encourage everybody to come and exercise your lungs a little bit. And been through pulmonary rehab a couple of times. So, yeah.
I'm Phyllis too. I've been through the pulmonary rehab twice. Surgery in between that. I have interstitial lung disease and pulmonary artery hypertension with CTIP, which is blood clots in the vessels. And that's what they took out. And I went into the hospital doing 6 liters of oxygen on the machines. I'm now doing machines with no oxygen.
Jones for being here.
We might be cousins. We're trying to figure it out.
I had COPD, but in my past life, I moderated several different support groups, so I'm a huge fan, and I've seen the value of them from this side. So now I'm getting it from this side.
Thank you, Sharon.
My name is Gwen, and after Mary rehab, I had COPD. And then triple bypass heart surgery. I was probably that. My name is Yvonne Buck. I was here to go learn how to play and do it. It's really fun. And I did pulmonary rehab here. And I have COPD and the schema about the and that's kind of it.
That was a lot. Yeah. Thank you for being with me, Vaughn.
My name is Joyce Miller, and pulmonary rehab patient. Breast cancer survivor.
Welcome.
My name is Gladys. I was diagnosed with cutaneous T-cell lymphoma in 2012 and strictly treated. I got pulmonary hypertension. So I was that flow.
And you were here for harmonic.
Yeah. But basically, when we get on things get.
The parts start to wear out a little bit.
Yeah.
Yeah, I turned 50 a couple of weeks ago and I'm like, that is not where it used to be. It's a real thing.
My dad.
Okay, don't scare me. I'm loving this one. Loving this.
I'm a third older than you. I could be your mother.
Amanda's like, I'm not the baby anymore. Okay. Nadine, your turn.
I'm, hello, I had interstitial lung disease and received the gift of life via double lung transplant back in 2014. And then blood no longer makes sense, and also in harmonica.
I love all the plugs for Monica today. This is fantastic. Really quick, they'll talk more about themselves, Darcy and Rocco. Okay, we're gonna do the staff, and then I'm gonna be close to shutting up and sitting down. Okay, Jamie.
Hi, everybody. I'm Jamie. I'm one of the respiratory therapists here in pulmonary rehab.
I'm Lily. I'm an exercise physiologist here, and I've been here for a year and a half. I'm Alex. I'm a respiratory therapist.
Heidi.
Michael with RT's here.
I'm Molly. I'm also in the RT.
We have a special student in the center.
Grace. I'm a respiratory therapist student here for 2 days.
Grace, all the way from
Missouri.
And I'm Amanda. I'm also one of the exercise physiologists here. I've been here, well, using them for almost 5 years now. But with home rehab, about 2.
Woo-hoo, to the staff. We have a couple people online with this. There are handouts at the front table, and there's also some that are on the tables that we have. One of them, Bella put together, she's online today, but she put together some resources for us. And so you can just scan the QR code with your phone and that'll pop the information up that way too. I just want to encourage everybody to grab the handouts that we have if you haven't already. And okay, Jamie's going to show us how to breathe.
and play basketball here too.
Yes. Okay, I'm gonna come over here. So, as you all know, breathing is an automatic response in our body. However, the respiratory system and breathing is the only system in our body with both autonomic and our control. So I really feel like your, not just me, but your breath is your most important tool you have. So I just want us to close our eyes. Sorry if you're eating, just say just a minute, digestion. We're going to come back here, but I just want you to close your eyes and I just want you to feel your breath in your body. No manipulation. Feel the cool air coming in through your nose. Feel the warm air coming out of your nose. Start to notice your breath. Notice how when you breathe both in and out of the nose, how your belly starts rising and falling. Your diaphragm is a very efficient muscle meant to last us our whole lifetime. It'll do all the work for us. Slowly go ahead and open your eyes. And just notice that tool is available to you all day, every day. So if you just need a little break throughout the day. Or maybe you need a little to go to sleep like Phyllis from something to figure out. But anyway, always good. So I want you to always just come back to the breath when you need it. All right.
Thank you, Jamie. So today's session is an intro to palliative care. As I mentioned earlier, we have Darcy, we have Rocco. They are both nurse practitioners with the inpatient care team. Say that right? Yes, awesome. Yeah, so turn it all over to the both of you. Thank you.
We'll probably stand, but if at any time you can't hear us, please let us know. We're
This
usually
is-
pretty good at projecting, but please let us know.
This is from my 3-year-old said that a Paw Patrol pup had to come help me today.
Oh.
She always knows I need help. So, but why don't you do a little introduction about your story?
Yeah. My name is Darcy Campbell. I've been a nurse for it'll be 28 years this year. I've been a nurse practitioner for the last 8. I've done so many different things in my nursing career. I've worked in the ICU, I've worked in cardiology, and then the last 8 years I've been working in palliative care. And I've been here at the university for the last 4 years. So I've had a lot of different experiences that brought me here and really, really love this work. So.
Darcy's been a mentor to me. I'm a newer nurse practitioner. I've been with the palliative care team for 5 years. Before that, I was a RN on the floor, on the bone marrow transplant floor and the oncology floors. And then I got into nursing because I was faced with a serious illness myself. I'm a cancer survivor, and that changed my career from engineering into nursing. And I'm not looking back. I love what I do, and being in palliative care, we'll learn more about is our passion too. So.
And thank you guys for inviting us today. I hope the topic didn't scare people away, but we're really excited to share this with you guys.
Thanks. So just some objectives today, what we hope to accomplish, just defining palliative care, our team makeup, how we fit into the healthcare system and into patient care, the importance of advanced care planning, which we'll dive into today, and some Colorado law surrounding that. And then, if people are up for it, starting the advanced care planning journey today. We hope to, these are some really cool images I found online, and I think this one speaks to me, having a little kid, and I think a lot of times providers and the medical system can just label us as someone with COPD, someone with lung cancer. And we know that there's more to everyone's life behind their illness. And so that's something that we do, is we kind of get beyond that illness and learn what people's stories are. This one's really busy. There's a lot on here. Yeah, go ahead. Let's see.
So palliative care, we are specialized medical care, and we work with patients and families who are experiencing a serious illness, and we can come alongside any point of that illness. Things that we focus on are pain and symptoms to improve quality of life. So certainly things like shortness of breath, anxiety that comes with shortness of breath, pain, constipation. Our goal is to really manage symptoms to help people feel as good as possible in their body within the setting of their illness. One of the things that we love about our job so much is we really want to learn about the person as a whole person, not just like Rocco said, someone with COPD, someone with a lung disease, who they are, who are the important people in your life, what are the things you like to do, and then really work to how do we match the things that make you who you are with what we can do within the medical system. And we often work really closely with the pulmonology team or the other providers taking care of you. Sometimes our job is helping with difficult decisions and helping with communication. I don't know if any of you guys have had the experience. Sometimes you get a lot of medical jargon and you thought, I do not know what they just said. And so we want to make sure that people understand what's going on in their body, and that you guys know all of the things that we know and what options are. And really, it's about offering an extra layer of support in addition to all of the medical care you're receiving. We don't replace any of the specialists in your team. We don't replace any of your doctors, but really about adding extra support. One of the things that makes palliative care unique is we have a whole team approach. We believe that we're all whole people, and the best way to provide whole person care is to have a team. Often we have nurse practitioners, we have physicians, but we also have social workers, we have chaplains, really to make sure we're looking at the whole person. And again, a palliative care is appropriate at any age and at any stage of a serious illness. And the big thing we want you guys to know today is palliative care can be done alongside curative treatment. Sometimes people say palliative care and they go, oh, this must be the end. And that is not the case at all. We are really there to help with whatever the disease, wherever your disease course takes you, we're there to help support patients.
Right. Yeah, I think the important thing is like that, what Darcy says, like we don't replace anyone because us as extra layer of support. Often, part of like Dean, I've never met you, but part of the transplant process here at university is we do meet all the pre-transplant for lung transplant patients. And just to kind of lift up who they are and what their story is, what they're hoping for, what's on the other side of that transplant, what we're working to get toward. So yeah, I don't think we got to meet, but
No.
yeah. This is kind of some of the misconceptions that Darcy is putting light on is I think that before this is pretty much we were a new specialty that came along in 2006, so we're one of the newest specialties in medicine. So a lot of people don't really even know palliative care. So our job is to learn more about it, right? And this was what it used to look like, and then towards the end, like once curative treatment stopped, you kind of started engaging with a palliative care team or like a hospice team. This is kind of the new, system that we've been trying to incorporate into care is we're not just, coming in at the last minute. We're meeting people when they first get diagnosed with illnesses. So we can kind of, speak to them. And also, sometimes I have to be the wheel that's noisy and to the providers and say, hey, this is something important to them that we need to get to the bottom of. But as you can see, as like the disease trajectory continues, we tend to be more involved, and that relates to people planning more for those transitions to hospice. So what we're seeing is people engaging in hospice earlier, which is a benefit that we can use for years if we need to when we're ready for it.
So hopefully you guys can see this, but oftentimes this is what the trajectory looks like in the series of a chronic lung disease, knowing that everybody's condition may be slightly different, especially thinking about things like interstitial lung disease, COPD, pulmonary hypertension. It's kind of this very slow progressive trajectory. And then there's dips in the system. So you can be going along having a dip. Maybe the dip is a pneumonia and you have a setback. Maybe it's an acute worsening of something. You have a little bit of a dip, you improve, but often you don't quite go back up to that previous level of function you had. You get most of it back, but not quite.
And sometimes you do.
And sometimes you do. And so it's often, and I'm not sure if you guys have seen this with your own experiences too, you get these dips. Maybe you end up in urgent care, maybe you end up hospitalized, and then the goal is to get you back home and get you back to your function. But over time, a lot of these lung diseases can be progressive, and this can be years of this trajectory.
And this slide just kind of shows how palliative care hopes to fit in during these times, right? When we're hospitalized, we come in and we provide more support. Hey, like let's get to the bottom of this. What's going on here? Can we help with symptom management? Can we help with planning the next steps? And so that's how this like step up kind of matches often a disease process. Yeah, and I think this is where Darcy and I really love a big piece of our job is to, where do we start? And we start by learning about people, learning what's most important to Darcy and like what she's, what's on the horizon for her, what gives her value, what puts a smile on her face. And so we can lift those things up throughout their illness. I think, that's something we start with. If you ever meet us in the hospital, that's something we start with. We say, hey, let's put all the medicine, all the stuff that's going on right now aside and just talk to you about a person to person. I want to learn, like, where are you from? Like, who's your family? What's your support system? What's your faith in support? Are there things that we can do in the hospital to support you through a hard time and bridge you to getting better, right? Some questions that just put on there. And my family's Italian and we're like from the East Coast, and Rocky Balboa is a big thing for us. So like, being able to like, it's a big piece of like the Italian fight is like that. You can do it, run up those steps in Philadelphia. And but so I think family's big for me. Faith. And some people like will tell me all kinds of things like, hey, it's really important for me to like be able to hike. So like, what treatments align with like getting you back onto the trail? Some people say I don't like to hike at all. And the most important thing to me is like being able to go to church on Sunday. And so we work towards what treatment's going to get you there and what symptom management's going to help get you there too.
I'm just wondering if anybody feels comfortable sharing, looking at these questions of if you're having a good day, what are you doing? What puts a smile on your face? And this is kind of a bigger, harder question. If I could not do or be whatever, I wouldn't be me anymore. Does anybody have thoughts or anything they'd want to share?
I just need to be around people and visiting with people.
Yeah.
I don't do well being alone. And I'm happy I can still go to the gym.
Social connection. Yeah.
What puts a smile on my face is usually food.
Me too.
This guy is doing the Italian, so I didn't.
Anybody else? Anyone here too? You guys can chime in too.
I always say that if I can't ski anymore, then that's like taking my car keys away from me.
Yeah.
Amen. That's the thing that I like to do. It puts a smile on my face
Gotcha.
and gives me a good day. Even when I have to strap oxygen in my backpack to ski, I still get up there and do it.
That's awesome.
I want to dance.
Dance.
Oh,
Hard.
Yeah.
I want to go for walks in the park with my grandkids. Hard. I just want to be able to do some of the things. I know I can't do all the things I used to, but it's those little things, and I want to be able to do.
Yeah. And these are the things that give our life meaning. These are the things that define who we are. Social connection, family, food, this physical activity. These are all the things that are so important, and they're unique to each person too. I'm having a good day when I get a text from my kids who are in college.
I'm having a good day when I come here.
Yeah.
And I have a good workout. It just makes my day go smoother. And this is what's making me happy right now, knowing that I need this. And since I've been here, I've learned so much. So I appreciate these classes.
Thank you, Virginia.
What makes me smile? I mean, I think I have 4 daughters. I have 11 grandchildren and 6 great-grands. And they're all over the place. But if I'm from New York, I have 2 daughters here, point in time. So, and when there's age to read with me, I went home last October, but then it was my mother said, what I was and all comes in. They now get online Saturdays, and everybody could read that way. Because we, North Carolina, South Carolina, anything like that.
So you do that every Saturday? You guys get on like
Yeah.
video call? That's cool. Love that.
And they basically.
Yeah.
We appreciate you guys sharing those things, because this is the important stuff that that you guys are doing the work for.
What about everyone in the back? And if you guys have anything that you want to share, what's important to you that you feel gives your life meaning, what it speaks to your soul?
I would say when I'm having a great day, I'm active.
Okay.
Getting good work out.
Nice.
I do, more of a comment is, you know, I remember when I was on oxygen, you know, 24/7, and, you know, your life really becomes oxygen management. And you're doing it constantly. Make sure you've got enough oxygen if you're going for a hike, or, you know, I remember one time my wife and my 3 sons, we went to Red Rocks to see Zach Brown Band.
Oh, cool.
So all 3 of the boys and my wife had oxygen tanks in their backpacks. And I went through almost all of them.
Wow.
We go through one just going up and back from to the restroom.
Making it work.
Yeah, so I always did the sea tanks, you know, my backpacks. What oxygen made of me for, you know.
Yeah, I think when you live with a serious illness, you learn how to, like, there's only so much in your tank, right?
Right.
And you have to like say, hey, all right, I'm gonna reserve this much for that phone call I'm gonna have with all the kids, you know, today, and like maybe not do other things today. So
that's what made me happy when I was, you know, struggling.
was it a good concert?
Oh, it's great. We see him again in October.
Oh, awesome.
Anything.
Yeah, I need to go. You have something?
Yeah.
Yeah.
A really great day today. It's my last day at work. I'm retiring. And so I just have found that my heart is like super light today. And so I was looking at number 1 and I'm like, oh, what am I doing when I'm having a great day? I'm retiring from my job. But I think that what it is for me more is just this transition into whatever my next phase is. And it's so bright and beautiful that I'm just like really stoked about that. One of the things that puts a smile on my face is, especially a day like today, like getting outside, walking, particularly with my mom or one of my kiddos, and just like sunshine, fresh air, and a good walk is just, that does it.
See the happiness on your face.
I hope I'm
You look good today. We appreciate that. That's a big part of what we do, is when we meet people, we talk through those. And then we talk about how can we achieve those things and make them happen, right? Another big piece we do is you know, weighing options. We talk to, you know, pre-transplant folks about, you know, what to expect when you're going through a transplant, like how it alters your life in different ways from when you're pre-transplant. So we talk through those things, talk about the risks, benefits, and burdens. The third thing, burdens, is something that a lot of, you know, docs, we just don't talk about. Is like, what do I got to go through for this treatment? What, you know, just an extra thing that's often left out. So that's something that we bring in. And oftentimes I'll go like to the physician and be like, okay, like the risks and benefits for these, like, what are they going to have to do in order to go through this surgery and through this treatment? Like what are those things? How many times they got to come to the hospital after this follow up? And so we tend to put that into the hat too, just to make sure people have an educated decision before they move forward with something.
So, that kind of transition us to starting to talk about advanced care planning. And, you know, we prepare for a lot of emergencies in life. Probably have car insurance or homeowners insurance and these things that protect us. And advanced care planning is a way that you can prepare for health emergencies and help your family prepare for any potential health emergencies as well.
As I'm looking at this like shopping cart here, I can't help but remember when I grew up in Dallas, anytime it was about to snow, people would go to the store and just like fill up their shopping carts and stuff. And you go in there and be like, is it Armageddon? What's happening? Well, you don't see it as much here. So the advanced care planning, it's kind of a broad, covers all the things, but it really, you know, like I was saying, like it lets your voice be heard. Making sure, I think a big thing about this for me is I've found that families really appreciate when their loved ones know, you know, what their kind of lines in the sand are, like, and what would be too much. It's actually the conversation project down here. It's from the Institute of Health. Started about 10 years ago, and it was it's all about advanced care planning. It's a great website if you ever want to check it out. But what they have found in their studies, it shows that surviving families, you know, after their loved one's death, that they have, you know, less stress, less anxiety. The bereavement process is a little smoother. It's never easy, but it seems to be studied that when we plan for our care, it helps others that we love.
Don't wait.
The
Conversation project, yeah. Yeah. You don't have to do caps. Yeah. If you just put it in this browser, it'll pop it up.
And then an advance directive is a written document done in advance that gives guidance for your future medical treatments in case you're not able to make decisions for yourself. So we always want to pause and have thought when things are calm and going well, because that's when we're at our best self, so we can think through things. So we're going to kind of talk about two things. One, Rocco brought, and I believe they're on the tables in between, is a medical power of attorney. I'm guessing when you have a lung transplant, you probably completed a medical power of attorney. Yeah. Just check, and this is not judgment, this is just more curiosity. Does anyone know if they've done a medical power of attorney at some point? Okay, fabulous. So this is a document signed by the patient naming who would make decisions for the patient if you're unable to make decisions for yourself. When my children turned 18, I gave them 2 weeks. I didn't make them do it on their birthday, though I asked them to. That's what happens when your mom's a nurse. Like I said, we have to have you name someone. And I said, you could be me because I'm a nurse, but it doesn't have to be. But we can have you guys complete it if you're interested. And then the second part is a living will. And this is a document that's signed by the patient that states what type of interventions you would want in the event of a critical or a terminal illness. We're going to talk about some of the options more, and we also brought some too if you guys are interested.
This is kind of like my go-to when I ask patients when I first meet them and they don't have it, which you guys like. I noticed like a majority of the room has it. I didn't see anyone else hold their hands up though, because everyone, you know, in the state of Colorado, it's not next to kin law here, and so you have to complete this document to state who your person is. And this is like just kind of like something I start with. I just say, hey, like if you ever get so sick and fuzzy you can't make decisions for yourself, like who should I reach out to? People often go ahead.
What happens if you don't have? We're going to talk about the problem.
It's a good question. And so someone often says, you know, like Darcy. I say, okay, Often that stops after the conversation stops after that. And so we encourage people not to stop there and to get the documentation done. And so I talked to a lot of nurses because like they do the intake here in the hospital, right? And they ask this question, who's your emergency contact? They're like, don't stop there once they say who it is, because it's we legally we need to keep going. So these are a couple of the forms. This one I have right here that I brought with us. The third option is like, you can always go to, you guys probably have My Health Connection app. There's a questionnaire section. If you go to the questionnaire section, your MDPOA should pop up. And then you can do it electronically. And once you fill it out and submit it, it's like in our system forever. Until you,
It's hard for people to find in the system.
it is hard to find, yeah. It is. Yeah, like, yep. We're trying to get better about that. I mean, like I mean, in our hospital, only, less than half the people that show up here have one. So we're getting better at asking the questions, and the documentation through like, all the AI stuff is getting better. It's linking them better.
So Rocco, real quick.
Yeah.
I've had my mother fill this out.
Mhm.
And she has Kaiser permanent day.
Yeah.
But she comes and gets care here sometimes.
Okay.
So we've done this, but when she's at Kaiser, she's like, it says it doesn't fill it out. Is this specific to UC Health then?
No, it's not.
Okay.
So this is the laws are different in every state. So like the way the law works here is that it doesn't go next to kin. So my wife isn't automatically my decision maker. I have to fill this form out. I have to, put my name, date of birth, who that person is, contact number, and sign it and date it. And that makes it legally binding. There's a whole back side of this that has, like where you can get it notarized. I mean, it's okay to do that if you want to, but the way the Colorado law works, as long as you sign it and date it and it has your information on there, you're covered. And so like what we have people do is folks that like get care at Kaiser and we just see them for a minute, we say, hey, like, let's take a picture of this on your phone. And so anytime you go anywhere, you have it with you, so you can show people. Is a good trick we use. But yeah, it's always tricky because like I wish, one of these days the medical system records will be all, you hope, right? But it's just every system has a separate thing, and it's really frustrating. There's some things that you have to qualify for. Like I'll have a family member come in. It's like, it's my son. I'm like, how old is your son? I'm like 16. I'm like, oh, I think we're gonna have to update that because it has to be 18 or up, mentally competent. So I mean, sometimes this happens to us. Our loved one ages and we develop some disease process where they really can't weigh decisions for somebody. And so it's really important if you do have like your spouse on there to have like that next person listed too, or just keep it updated, because anytime you update this, you put a new signature with a new date, it replaces the prior one. So.
I've made a thumb drive
Nice.
with all of these documents on it.
Nice.
Given it to my son. so
That's
that when
amazing.
he's called, he's got everything right there with him.
Yeah, that doesn't really, that's amazing. Yeah, and I think this is something I put on there just because if you have a living will, the medical power of attorney can override some of those decisions. So it's sometimes like we do these things in isolation, right? We pick a decision maker and then we fill out our living will, but we don't bring them together. And we see it a lot, like when loved ones show up and they're like, oh, they wrote down this stuff. I'm like, yeah, they did. Did you guys ever talk about it? They're like, no, we never talked about these things. And so I think the first step that I like to think that a medical power of attorney triggers is that next question from the person, like, Darcy, you picked me, like, what do I need to know about you that's important, that I want to make sure I make good decisions? It doesn't always happen, but sometimes it triggers that thought in folks' heads.
So when you're considering who would be a good medical power of attorney for you, things you want to think about is it someone who knows you well and understands what's important to you? Will this person be calm and rational in our crisis? So I think sometimes the people that know us really well, it might be too anxiety provoking for them to you take that on. So you want to think about who can be neutral or who can handle hard information and process it. And then are they willing to do this? So you want to make sure that the person, hey, I think I really trust you. Is this something you're willing to do? I think one of the things that Rocco and I see a lot is a really good decision maker can be able to say, this isn't a decision I would make for myself. And yet I love or respect this person enough to honor their wishes, even if it's not what I would choose. And so you want to choose someone who can be thoughtful and say, I may not choose that, but this is what they would want and I'll do it anyway. And then, I think, like you were saying, you have family all over the place. And so while people don't have to live locally, at least
All four of my daughters are
okay, you just have to be able to empty but up.
they live in I had to be tough. And my daughter lived in Green House. And I was in that, so I live in it's black Charlie stuff. And I had it.
Something's going on.
So I called her and I said, I need to go. She said, okay, Mom, come up to the phone next to your manager. She was there. And they couldn't get me here. It was all time record, everything was here. And they told me from Havana and Dayton, after that later over there in the seniors. And they told me, if we take we work over and in my mind, after all the years I've been with these people, 24 was real coming. I said, I don't know, I prayed on it. I looked at the attendance because when the babies are small, I have been through 8 weeks and kind of implants and stuff. So she couldn't even get a line. And this lady kept jabbing. So I'm going in now. And I said, stop. He said, "No, we're not going to try and get out. But if we try to take you good, you see how you're not going to take it." So they took me to a lower home. And it was awesome. Because when they took me to the emergency, my daughter that was with me, she's a middle child, she's still there. But she was so flabbergasted because they got me on this table. I was going in and out, all this mess. And the nurse kept telling me, you can't stay, you can't stay. And I could hear. And I know that's the one child I have. She can't handle stress. She can write letters, she can do all the official stuff, but she even told Mommy, I'm not a caregiver, but if you need someone, I will take someone to take care of you. Because it is when there's a only thing. So when I got to the hospital, like I said, I'm on the table, and the doctor told her, you can say, he said, he asked me, did I have a big road at that time? I did. But I had already told my kids once and when I can't. If I'm gonna be a vegetable, let it go. Yeah. I'm not gonna spring back because my mother had come in music till she was going back. Okay, in her life. But I said, I can't afford myself. Let it go.
And that goes back to that question of it.
My daughter, because she was standing there, and she was in, I felt so bad because she's 47, so she's not really good. Okay. And she was like in a fetal position crying because the lady was trying to get her out. So the doctor said, leave her alone. You stand in the corner. So they asked, so do you know what your mother wants? Does she have something in writing? She said, well, do you like to discuss it? So she told him exactly what I just said. My mother said, if she's not going to give herself and have a good quality of living, let her go. They had to restart my heart 3 times.
Wow.
And by the time I woke up, I had to straight down my road. And it was the next day, by then, that night, all of my daughters were here. Because my mother, she's all faith with me. And my daughter, was I joined the building. So we're champions. That's how we do. And we don't put up the way we take the edge. So we went on her words. They were so happy. But they said, Mom, your heart stuff. I know that. Without give up.
Sounds like you picked the right person.
Um,
Sounds like you picked the right person
Yeah.
to be your voice.
Well, that's what they do. They all, now they all, this is, I did my youngest school. Because that, actually, they took me to Florida. And the doctor said, no. She said, yeah, she stays. So they had to deal with it. A sister in New York and managed got all this video stuff. We could see the people. Yeah. They would ask questions. It was this, that. They were looking at me, feel my stuff. My sister said, no, it's not. And she's 10 and she's up with 7 times. So she did the welfare administrative course, so she pulled out different things. Plus, she could be on the executive that she thought that it.
When we have like in a scenario when we don't have a decision maker in place, like that's the question you had, which we run into a lot in the hospital. There's it's called a medical proxy we have to do. And so what happens is we have someone comes in, they're not able to speak with us. We reach out to anyone that's on the chart, say, hey, Darcy, is there anyone else that would be interested in what's going on here? So yeah, like so-and-so, the barber, maybe like anyone that's interested. The guy's been cutting the grass for 50 years. And so anyone that has interest, we have to contact legally. And so it takes some time and it can delay care. That's the big thing we run into is delayed and sometimes, medical decisions of a certain treatment. And so we have to gather people. It's usually the social worker in our team that does that. We call and say, hey, who's the best spokesperson, for Darcy in this situation? And
So in that case, say, you're crashing and burning,
yeah,
you're on the table, they want to save you. So you have this list of people. Can they not do anything until they contact somebody that says this is their wishes?
the default is we do everything. There's no limits, right?
So they continue doing everything even though you have told somebody who's not around anymore.
Yeah.
That you don't want, if you're gonna be like she was, you're gonna be a vegetable, just to let you go.
Yeah.
They're still gonna try to keep you going. They're gonna have you on all that artificial stuff. So you're really not a person.
Yeah, if you don't have the MDPOA document, or we can reach out to that person or a living will that we have on file and can follow.
So if there's nothing out there, how long, okay, say I'm 110 and, I'm crashing and there's no hope for me.
Yeah.
Do you just put me on life support if there's nobody, no family and no close friends around?
The default in the emergency situations, yes, we do those things.
So
once
You just room on artificial for another
until
100?
until one we figure out like who's the spokesperson that we need to. And this usually happens within hours. We have phone calls. We try to find as many people as we can and we get to a consensus on who that person should be. It doesn't have to be an all out vote, right? But hey, now obviously the example that's like a scary example, right? That like people can go through. And then even like that example where you do all the things, sometimes when we get to a point, there's questions like, do we do this treatment or do we do this treatment? And so at that point, if we still don't have a decision maker in place, what we do is a physician proxy. And so we get, usually it's a physician that's not associated with that care at all. And then they make decisions based on the medical situation. And if we have a story from them, our patient, we're usually involved and said like, oh, she's someone that, you know, is very, like to stay interactive and social with people, wants to get back to her independence. So that weighs into those decisions. If we need a. some physician proxy.
All these people that don't have anybody.
We don't. We don't. Yeah. Yeah. There you go. Yeah. Cool.
Yeah, that one, at least they have something to fill on.
That works if you have a tattoo of it. We cannot go off the tattoo. Yeah, go ahead.
There's also where we, go, you said that if you go into the races and, there's nothing, the medical staff, there's nothing they can do. I mean, I've sat in on some non-beneficial interventions and, it's pretty wild. I mean, the families, think there's going to be some divine intervention and there's, absolutely nothing that can be done. It's tough.
That's really tough. And,
It makes it tough on the family.
staff, it's hard for, the whole, everyone surrounding that
And
patient.
medical staff.
Yeah.
Jessica, how are we doing on time?
Yeah.
We're getting close.
Close.
Yeah. Okay, I want to keep going. We got a few more things.
Yeah. Go ahead. This is just talking about living will, yeah. And for living wills, we brought one that this is the one that I love, called Colorado Advanced Record. It's state specific. And the first section 1, just talks about that the medical decision maker we've been talking about, having that person up to date on what you want. And then part 2 talks about interventions that you're okay with, and everything from, like life support measures, anything from a feeding tube, dialysis, pressures to keep your blood pressure, or medicines through IV to keep your blood pressure up, a ventilator, and non-invasive ventilation, such as like a BiPAP or HIPO is also considered a source of life support. So there's a lot, they go through all these things, and really this is a tool. This one, I like this a lot because you could sit down with your loved one. Like I've done this with my dad and my mom, which was like filled with tears and also joy that we talk through these things. But just talking, it's a conversation tool, really is what it is. And so, I like the way this one puts it through the questions. It's not so, like the 5 wishes can be a little bit more about death. This one talks about things that you want when you're still living. Right? So it's a conversation tool. That's what we like to think of it as. Living wills, like attorneys can do them too, right? They do the very specific ones like X, if I'm incapacitated, if I'm in a vegetative state, there's a lot of gray area around there that this one fills in the gaps for. And so this is a more medicalized approach.
So what's the difference between doing something like that versus the green sheet?
Yeah.
Yeah, the green sheet is called a MOSE form, or medical orders for scope of treatment. And if you have a DNR or a do not resuscitate, that is what that order goes on. So that's a little bit more advanced and more higher level of, essentially it's a doctor or a nurse practitioner orders that follow you with the thoughts. So it has even more details about your care. So.
But if you're taken somewhere that's outside of this area, how do people know that you have a green card, a green sheet?
We see this a lot. So one of the things we recommend is whether you have a medical power of attorney, a living will, or a MOSE form, take a picture of it and keep it on your phone. The other thing is share it with your medical decision makers so that they have it. I have my parents hold their medical power of attorney and their MOSE forms on my phone as well.
Anytime you update it, we always go by the most recent date. So often people with serious illness have, most forms where their wishes have changed. And sometimes they go, back and forth. It just depends on what's going on in their story at that time. But we just go off the most recent date. We had some things to talk about with symptoms, but I think that's I think in the grant, like with respiratory disease, like, we always try to help with the physician to think of all the tools that we have, right? For the bronchodilators, the steroids, those types of things. Like we go through, like they've done this, they've done that. If we get to a point where those things are no longer helping, we tend to reach for other things. Opioids are actually a studied tool that show that it kind of tricks your brain into thinking you're not so short of breath. So when people are finding that all the treatments they're just not working, we tend to reach for those at very low doses to trick your brain to saying, hey, I'm not so short of breath. And it really we've seen it work really beneficial with people, and they usually reach for morphine first. I was doing that quick just because you got time.
To your primary care, that can help guide questions about your lung disease. So you might want to say, as this disease progresses, what can I expect my life to look like in the months and years ahead? What can I anticipate? If I have a setback, whether it's a pneumonia, GI bleed, something else, would I benefit from life support, such as a ventilator? We know for some lung diseases, we hope that if we can fix the infection, then someone can go through it and come off of it. For some people, their lung disease is really advanced. And if you have to go on it because your lung disease is advanced, we don't know if you'll come off of it. We can't speak for you guys, so it's why you should ask your provider. What do you think would there be benefit in going off of life support? Would it be a reversible condition?
My question for doctors, usually when I'm talking about those things with patients, is like, if we do this, is it a bridge? And if they pause, I would pause too, right?
Yeah.
And so I think if they're offering something, they're like, this is a bridge, it's gonna get you back over to where you were. I'd be like, okay, let's do it. Instead of getting on a pier, right?
And then if you are getting to a point in your lung disease, you start noticing you're having more bad days than good days, maybe you ask your provider, would I benefit from a palliative care consult? That can be done not only here in the hospital, but there are community providers like nurse practitioners and physicians that they go to your home. It's about once a month, not super invasive or big use of time, or a clinic, and can just help talk through some of these things too. These are complex decisions, and it can be really helpful to pause and really talk through things. And then always ask your provider, what else should I know about this illness? What else should I know to tell my family?
Yeah, just briefly, a plug for us, right? Our palliative team, we really enjoy caring for people that have serious illnesses, and I think once you'll find that once we're engaged early on, we can kind of be an advocate for you, especially in a really large medical system, trying to get answers for you and squaring, us being the squeaky wheel at times, like I often am. And so early engagement. I mean, we build trust. I've worked with patients for many years, and really cherish those relationships. Yeah, and if you ever think, hey, like my physician or my nurse practitioner or my PA, whoever you see, is not being truthful with you, like I feel like we are the true speakers in the medical field, and so we tend to, we kind of gauge on how much you want to hear, but also like we can speak truth from our experience, what we witnessed with patients in similar scenarios. But yeah, we appreciate your time. I know we ran short, so but yeah, I was glad it. Thanks for all the great questions too. Yeah. From like Eastern Rome, it's a little tiny town. So pretty much like between Rome and Naples. My dad's family is north of there, my mom's south. Yes. Yeah. You got it. Okay. Yeah. Something to see, and I took part of my mom's and anybody's.
Like, parents didn't cover their farm property. And then oh, yeah, yeah. Where's the print making?
Came by the chapter. Yeah.
Living?
Survey.
We're gonna do
So a couple of reminders to give everyone really quick. Next month is probably one of our most popular topics. If you're gonna be here, please come early. I know parking can be a little funny that day if you are driving or riding with someone. So that's May 26th. And it's Dr. McLaughlin. And that is on the bottom of today's meeting agenda, and also hopefully everybody gets the emails from Jamie. If not, please make sure your email address, if you have one, is on the sign-in sheet, so we can make sure we're communicating with you all as best. Jamie just passed out the evaluation. So thank you. I see everybody feeling loved out. Thank you for doing that. Would you include on there if anyone has any type of dietary restriction? If it's salt and water. It's funny the amount of time we spend on the menu. And so if there are any restrictions, we'd like to try to be as cognizant of everyone as possible. And then reminder also, I think we talked about this, if not last meeting, the meeting before, for our different topics, if there is any one of you who has a testimony related to that topic. I know that we talked and we asked our questions in a moment, but if anyone wants to kind of like document stuff, if anyone wants to share more and have more time to share your own personal story, we would love for you to do that. Today, Palliative Care, I was hoping that I would be strong enough to share my story. My dad passed away 6 months ago. Didn't think I would be able to. But funny enough, Darcy saw my dad 2 days before he passed away. He visited with him. So just another plug to how important palliative care is and how that you see that face 7 months later and it's like. So anyway, if anyone ever wants to share their story, whatever our topic is, please reach out to myself or Jamie, and we will make sure to make that connection. I think that is everything. Harmonic Cats, Tuesday at 11 a.m. in the little back corner room. We all know Movie Mountains is coming up in a couple of months. The Rockies. Thing in the Jigs in my school. How, yeah, I just. Oh, okay.
Yeah.
Okay. But that happened, so just to keep tuned in on different things American Lung Association is doing. And, that's it. Hope everyone has a great day. Thank you.
Oh, yeah, no, it was on.